And then a couple slides on urinary function and incontinence. And so basically, what does the bladder do? Well, the bladder stores urine, and then, when you want to urinate, it's all controlled. You relax the sphincter muscle, and that's in the red and here, and then that opens, and then the bladder squeezes, and then the urine empties, and that's how all that works. So incontinence is leakage of urine. So there are a lot of different ways. Overactive bladder means the patient they get a signal that they need to go to the bathroom, but they can't inhibit it. So the bladder wants to squeeze without them preventing it from squeezing. And that happens day or night. That's typically treated with medical therapy. Stress incontinence is leakage with coughing, sneezing, laughing, so any kind of exertion. And then urgent incontinence we talked about, and then mixed is a combination of both of those. And so most of the patients, the guys that I see, have been treated for prostate cancer. Although incontinence is not a big complication, maybe 4 to 7% can have significant incontinence that needs to be treated, but they typically have stress incontinence, and so cough, sneezing, or laughing, even gravity, standing up, they'll leak, and so obviously that's a big issue. So prostate cancer surgery, you'll see it in other conditions, diabetes, Parkinson's, and so forth, trauma. But there's no question that it causes mental distress. So if a guy has both erectile dysfunction and leakage, the leakage is a bigger problem far and away, because just being wet all the time, it limits going out, the smell of urine, it's just horrible. And so if guys could pick one, they would rather be dry. Unfortunately, we're able to do both operations in patients, and even at the same time, if a guy suffers from both problems with incontinence as well as leakage. But obviously, it's a big emotional issue to leak, and fixing it is important. So you can see these are some numbers on here. A lot of men suffer from incontinence. 3.4 million over the age of 60 may have some type of incontinence, and then again, the rates range on here, but significant. I think if you're looking at an accomplished prosthetic surgeon, numbers again, probably about 4 to 7% of severe incontinence. And so we have a spectrum of things that we can do. So what are some of the things? Certainly when somebody's just had prostate cancer surgery, they're on rehabilitation to try and strengthen the bladder muscles, Kegel exercise, maybe limit food, fluid intake, certainly avoid irritants, so caffeine, alcohol. Caffeine's a diuretic and will make you want to go to the bathroom. And sometimes we'll put patients on medicines, particularly if they have urgent incontinence, overactive bladder, to slow down the bladder from squeezing on its own. But that doesn't always work. And these are some of the other options. And again, these are all temporary things, so pads. And so again, those that have had incontinence, wearing pads is not a lot of fun. If you travel, I have patients who wear 10 pads a day. I know it sounds crazy, but that's where they come in, 10 pads a day. And so penile clamps, catheters, bulking agents, and surgical options. And so we can kind of, I think everybody knows what pads look like. They're expensive, and even though they've gotten fancy, they're not great. These are some of the clamps that are out there, very uncomfortable on patients that wear these things. These are condom catheters, so it's like a condom with a little hole in the end to drain the urine, and it sometimes can be very difficult to keep on. And again, catheters inside, risk of infection. So these are all sort of temporary treatment options for patients. Bulking agents, we don't really use those anymore. What's that? Well, that's actually where we look inside the urine channel, and we used to inject some material to try and bulk up where the prostate used to be. But it's not really very durable, and typically in somebody that's had prostate cancer surgery, they have scar tissue in that area. So there's no planes, there's no place to inject the stuff, so it just doesn't work. It's not a durable procedure. So we don't do any of that. I don't do any of that anymore. And really, if you talk to anybody that's does a lot of incontinence, post-prostatectomy incontinence, really nobody's doing that anymore. But luckily, we have some great treatment options. So on here is the male sling, and then the other one is the artificial urinary sphincter. The male sling is something that's been out now for about 4 or 5 years, and it's been great. I think we've had slings previously, But really, up until this one came out, I think that, we didn't do that great. We were fortunate enough to be one of the sites here, Urology San Antonio, so there are 8 centers in the United States that initially got this product, and I was one of them. And so I've had experience with it really from day one when it came out. So this is an outpatient procedure. It takes 30 minutes. This is for the guy that has mild incontinence. So maybe they wear just a couple pads a day. They're not big-time leakers. And there's some other things that determine if they're a good candidate. But this works great, and it's a great option for patients. Again, has some side effects. Everything potentially does. But overall, patients do very well with this procedure, and I think it's a reasonable option. It's not recommended for urinary tract infection, bleeding problems, that kind of stuff, but this is sorted out by your surgeon that does this. The artificial urinary sphincter, this has been around also since '72, so the same guy that came up with the penile implant came up with this, so Brantley Scott, and one actually gave the idea to the other. So this is a cuff, and you can see on here, so the cuff gets wrapped around the urethra. So it's like a blood pressure cuff that squeezes. There's a pump in the scrotum, and then a little reservoir up here. And so it's filled with fluid, just like the penile implant is. It takes, about 30, 40 minutes to put in. Also an outpatient operation. And so fairly straightforward. The patient still has the same signal in their mind that they want to go to the bathroom. When they do, they squeeze the pump, the cuff opens, they go, and then the cuff closes by itself. And so that's how that works, and it works great. You can see excellent patient satisfaction. Most people would have it done again. I tell you all these little tidbits from patients. So one of my patients from Houston has both a penile implant and an artificial urinary sphincter. He jokes, he goes, "I don't know, doc, if I'm coming or going." So so you have to have a sense of humor with all this stuff, right? So infection rate, very low. Patients do very well from this stuff, and fairly straightforward. You have to have good hands, and so good manual dexterity. So if there's loss of hands, then it's not a great option for patients. If they have a lot of scar tissue down there, again, not a great option for patients. But these are things that are sorted out with the physician that puts this stuff in me. And so, in summary, incontinence can be a common problem, but the take-home message here is that there's treatment. And I think that that's the important thing to understand, is that there's treatment for patients that have some leakage. Some treatments are more effective than others. We evaluate patients pretty thoroughly. We do tests on the bladder. We look inside the bladder for scar tissue. I mean, we do the full gamut so we can have a good outcome. And that's the goal, is getting a good outcome, and also so we can counsel the patient on a good outcome. And so, there certainly is treatment.